I'd like to welcome you all to the 128th Faculty Research Lectureship that's sponsored by the Los Angeles Division of the Academic Senate. I'm Michael Moranz, and I'm chair of the Academic Senate this year, and one of the great honors, I don't know why I say one of the great honors, the great honor of this position is that I get to host this lecture, the Faculty Research Lecture, which is designed to present the work of some of UCLA's most distinguished and imaginative and eminent scholars. Today, our speaker is Professor Michelle Kresk, who is the George and Joanne Miller Family Endowed Chair and Professor in the Department of Psychiatry and Biobehavioral Sciences. The purpose of the lecture is to allow the university and the Senate to recognize faculty for their superb achievements and to give the campus and the greater community an opportunity to gain a new perspective on scholarly achievements and the viewpoints of the faculty that are honored by the lectureship. This lecture began in 1925, so around the time I entered graduate school. In 1986, the Faculty Research Lecture Program was expanded to 2 lectures each year. Since 1986, there's been a lecture in the fall and a lecture in the spring of each academic year. The speaker has requested, this is slightly unusual to the usual request, that everyone silence their phones but not turn them off. She'll explain why later. And at this point, I'd like to present our Executive Vice Chancellor and Provost Emily A. Carter, who will introduce our speaker. Thank you.
Thank you, Michael. Good afternoon, everyone. It's really great to see such a large crowd. I know that the lecture is going to be spectacular. I'm reminded every day how fortunate we are to be in an environment with so many innovative and insightful intellectual leaders. The Faculty Research Lecture brings all parts of our campus together, showing us that we have extraordinary talent across all of the disciplines. Today, we are privileged to hear Professor Michelle Kresk deliver the 128th Faculty Research Lecture. Professor Kresk is a clinical psychologist working to understand the risk factors for anxiety and depression so that targeted treatments can be established. Really impactful work. As we all know, unfortunately, depression and anxiety are all too common and exact enormous costs on individuals, families, communities, and the economy. According to the World Health Organization, depression increased by more than 15% between 2005 and 2015. It is a serious public health challenge, with more than 264 million people of all ages suffering from depression worldwide. And of all medical and mental health problems, depression is the leading cause of disability and poor health around the world. Professor Kresk puts it bluntly. Depression affects our entire social fabric. Currently, less than half of those in need of care actually receive treatment for anxiety and depression. And while treatments can be effective, relapse is not at all uncommon. And that's why, when UCLA designed grand challenges to take on, depression was one of just 2. So it is one of our 2 signature grand challenges, and we are devoting substantial resources and energy to better understanding the causes and cures of depression and the prevention of it before it happens. Professor Kresk is a key leader of UCLA's Depression Grand Challenge. As the director of our innovative treatment network, she oversees screening, tracking, and treatment efforts for the entire UCLA student body. A prolific scholar, Professor Kresk has authored more than 500 peer-reviewed articles and several books. Her insightful work is widely cited by researchers and regularly utilized by clinicians. In 2019, she was recognized as one of the world's most highly cited researchers by Web of Science. Born and raised in Tasmania, Australia, she earned her psychology bachelor's degree at the University of Tasmania and her PhD in psychology at the University of British Columbia, followed by a postdoc fellowship at SUNY, at the State University of New York at Albany. She joined UCLA Department of Psychology in 1990 as an assistant professor. She became a joint member of the Department of Psychiatry and Biobehavioral Sciences in 2001. She currently holds the position of Distinguished Professor with, as we heard before, an endowed chair from the Joanne and George Miller family, and serves as the director of the UCLA Anxiety and Depression Research Center. Her influence, of course, extends beyond UCLA. She has been president of the Society for a Science of Clinical Psychology and the Association for Behavioral and Cognitive Therapy. She has been an associate editor of numerous journals and currently is the editor-in-chief of the highly respected journal Behavior, Research, and Therapy. She has received multiple awards of distinction since joining UCLA, including the Distinguished Scientist Award from the Society for Science of Clinical Psychology, the Outstanding Researcher Award from the Association for Behavioral and Cognitive Therapy, and the Aaron T. Beck Award from the Academy of Cognitive Therapy. Wow. Please join me in welcoming the 128th Faculty Research Lecturer, Professor Michelle Krask.
So thank you very much to the nominating committee and to you, the audience, for this honor of presenting the 128th Research Lectureship and a chance for me to share some of our advances on the risk factors and treatments for anxiety and depression. So I grew up in Tasmania, which is the island state to the south of Australia. And actually I grew up in Hobart, which is way down south. Which looks something like this, and I actually lived just around that corner over there. And it was really a wonderful place to grow up, but the mental health resources were terribly lacking. And my older brother suffered lifelong emotional problems that were never, ever properly treated. And so from the age of 13 years until he died many years later, he was hospitalized. And this was truly a nightmare for him and for my entire family. And that set of experiences growing up really drove me to become a clinical scientist to try to understand the factors that contribute to emotional problems so that we can develop better treatments. So before I begin, I want to do two things. First of all, as was already mentioned, if you have cell phones, and hopefully all of you do, silence them, but don't turn them off. It's a little secret. We'll get there, okay? Second, I want to thank the various funding agencies for my work over the last 30 years, and in particular the National Institutes of Mental Health, who have funded me continuously since 1993. And I also want to thank a wonderful set of graduate students and postdoctoral fellows that I have had the honor and absolute pleasure to mentor over the years. Now, my family story is not at all unusual. The problem that we face is absolutely enormous. So as it was already indicated, the rates of depression are estimated at around 320 million around the world today. In the United States, it's estimated that about 1 in 4 women and 1 in 6 men will suffer from a major depression at some time in their lives. And rates for chronic anxiety disorders don't differ that much, and often these two things go together. Obviously, these rates vary country by country and region by region, but everywhere, women are at much greater risk than men. And most concerning is that the rates are increasing. So you can see that from 2005 to 2015, the estimates of increase are about 15 to 18%. Now, the increase is actually even more apparent in young adolescent girls, where the rates are estimated as high as 1 in 3. and where rates of suicide are actually increasing. So my earphone just came off. There we go. So, depression and anxiety affect our entire social fabric, from infant development to economic gain. So let's take the example of postpartum depression. Postpartum depression, and anxiety is closely linked to it, affects anywhere from 1 in 9 to up to 1 in 5 women, depending on the region. And postpartum depression not only affects the mother, it also affects the offspring. So this was a study that was done of 8,000 children in the United Kingdom, and they were followed from birth to 18 years of age, and their functioning over these blocks of time were correlated with the mother's state of postpartum depression in the first few months of life. And what you can see here is that the odds ratio for having behavioral problems early in childhood, for having poor cognitive performance as measured by mathematics exams at 16 years of age, and of themselves becoming depressed by 18 years of age was particularly apparent in the case where their mother had both severe and persistent postpartum depression, which means that it lasted for at least 8 months. And so the effect of postpartum depression is transgenerational. It influences the next generation. And on top of that, there's a huge economic toll that comes with depression and anxiety. We're talking about things like poor academic performance in school, school dropout, poor work performance, disability, and often economic downward spiral into poverty. Now, even among our UCLA students, sorry, this thing keeps falling about, even among our UCLA students, you can see that the rates of depression are correlated with GPA. So this is normal, mild, moderate to severity depression, with as depression is increasing in severity, GPA is also decreasing, and that's controlling for age, race, gender, prior academic performance at high school, and the socioeconomic ranking of the high school area. So even among our own students at UCLA, there is an impact of depression on academic functioning. And so it's for all these reasons that depression and anxiety are now considered to be the leading causes of disability worldwide, and depression is projected to become the leading contributor to global disease burden above and beyond all other medical conditions by the year 2030. So the scale is enormous, and the impact is enormous. And that's contributed to by the fact that less than a half of the people who are suffering actually receive any kind of treatment. And of the existing treatments, we find that they work about only half of the time. So the scope of what we're faced with, as I said, is enormous. I believe that in order for our treatments to work more effectively, we have to understand the engine that drives psychopathology. And so in my own research, I'm looking at 2 drivers of that engine: the appetitive system, which motivates approach towards goals and rewards, and the defensive system, which motivates avoidance of threats or punishments. And so what I'm going to be talking about today is the risk factors, the neural pathways that emerge out of this research into the defensive and the appetitive systems, and the novel treatments that emerge from that, so that we can develop treatments that work better than just half of the time. So let's start off with talking about the defensive system and a general construct that I'll refer to as generalized expectancy of threat. Now, to do this kind of research, I typically use longitudinal studies over high-risk developmental periods. So this is a project we call the Youth Emotion Project. where we selected 627 16 to 17-year-olds, and we followed them for, on average, up to 8 years. And the goal was to identify what are the predictors of anxiety and depression in this group. And you can see that we did a whole array of measures of psychophysiology, of cortisol as a stress hormone, cognitive bias, early adversity, chronic and ongoing life stress, temperament, and symptoms of diagnosis measured every year. Now, as you might expect, we found that stress, ongoing life stress, is a predictor of who develops depression and anxiety. And as you might expect, we found that neuroticism, or that temperament towards negative emotions, which is a fairly heritable temperament, yeah, that's a predictor of who develops depression and anxiety, but we were more interested in the kind of mechanistic pathways of what explains those factors. So let's start with the cortisol data. And for those of you who are not so familiar, cortisol is a glucocorticoid hormone secreted by the adrenal cortex. It's often, broadly thought of as a stress hormone that has a diurnal rhythm. So it peaks in the beginning of the day and then tends to drop off over the course of the day. So our 16 to 17-year-olds, we somehow convinced them to provide us 6 samples of saliva throughout the day for 4 days in a row, and to send us those saliva samples so that we could analyze them. And what I'm showing you here is the average of the early morning awakening response. So just after they wake up, what's the amplitude of that cortisol awakening response? And then evaluating, does that predict who develops depression and anxiety over time? And what you can see here, these are 6-month intervals, and we're looking at hazard ratios. So yes, the early morning awakening response, controlling for all other factors that we measure, was a predictor of who developed major depressive disorder out to 2.5 years later. And second, it was also a predictor of who developed social anxiety disorder, which is our most common anxiety disorder, out to 4 years later. Again, controlling for all other factors. So we think of that, well, I should say one interpretation of that cortisol awakening response is a state of preparation for the challenges of the day. And so when it's elevated, we think of it as an anticipation of what could go wrong today, that kind of feeling of being prepared for what could go wrong. Now, associated with that, we find a set of cognitive biases in how situations are interpreted. So situations such as these, so just think of these for yourselves for a moment and how you would interpret these things if they happened to you. And so these are the kinds of ambiguous scenarios, and as you might guess, I don't know how you interpret it, but people who are at risk for anxiety and depression tend to interpret those situations in a threatening manner, which of course creates the experience that threat is ever present. So we have a combination of waking in a state of, we'll call it defensive anticipation, and a readiness to interpret threat around us at any time. But let's dig a little deeper here. So in a sample, a subset of those 627 individuals, we then took them through a paradigm where we wanted to measure the blink of the eye. So the blink of the eye, the startle reflex, which we measure through these electrodes here, is a very good measure of defensive response to potential threatening situations. So imagine you come into the laboratory. We have all these electrodes attached around here. We've also got electrodes on your hand to measure skin conductance and on your chest to measure your heart rate. And then there are these electrodes. So these electrodes, you are told the following. When this screen appears, you may receive a shock on those electrodes. And if you receive the shock, it'll happen as this countdown occurs around here. And you may receive up to 3 shocks during the course of the experiment, and each one may be worse than the last. And so we were clearly trying to elevate the expectancy of threat. Now, 4 of those screens were interspersed with 4 of this screen, which said, don't worry, you're safe, nothing's going to happen here. Now, in actuality, there was just 1 shock administered right in the middle of the experiment, and we did the 4 safe and danger screens before, 4 safe and danger screens after, and we looked at the average blink of the eye to an auditory probe as it was delivered while these screens were showing. And we wanted to see, does this strength of reflex to safe and danger predict who's going to develop an anxiety disorder or who's going to develop depression at a later point in time. And we did find an effect. But look at the result here. This is the average before that 1 shock was given, the average after that shock was given. It wasn't how strongly they responded to the danger screen. Everybody responded strongly to the danger screen. Their blink was really big. But those who were at risk for developing an anxiety disorder showed this elevated reactivity, this elevated defensiveness to what should be safety within a threatening context. As if you were to take the parallel from an example that might happen naturalistically, if there are kids on the playground and there's a bully, and this child over here is bullied. If that person who was bullied is at risk for anxiety, these data would suggest they'll not only fear the bully, but they'll start to fear all the other kids on the playground too, even kids who are friends. So it's like a spreading of the expectancy of danger after a single aversive experience, which may contribute to the pervasiveness of fears. But let's go even a little bit deeper now in terms of how do we update memories about what is safe versus what is... How do we update memories about what is safe versus what is dangerous in the environment? And to do that question of updating, we look at fear conditioning and extinction paradigms, because these are an excellent translational model of how we adapt to changing conditions of safety and danger in the environment. So for those of you who are not familiar with this, very briefly, what we do in these paradigms is that we pair a neutral figure, such as a geometric figure, with an aversive stimulus, like an electric shock, and we pair another neutral figure. We present another neutral figure without shock. So over a series of trials, the figure that's paired with a shock acquires conditional properties because it predicts shock. And so the individual starts to develop an anticipatory fear response every time that figure comes on the screen. You see it here in the stated expectancy of being shocked and in the skin conductance arousal, which is a good measure of fear arousal. Whereas the figure that's never paired with shock, you don't see that. It doesn't acquire conditional properties. Then we go through extinction. And this is now where the rules have changed, the contingencies have changed, because both of these stimuli are now presented without any shock. And as you expect, there's now an updating of the memory as the person realizes, hey, that thing that used to predict shock no longer predicts shock, and so their conditional fear response subsides. And then if we test a week or at least 24 hours later, now we're looking at long-term extinction learning, and there's a little bit of spontaneous recovery, which typically happens because some would say extinction's always more fragile than original fear learning. But this overall approach of looking at fear conditioning extinction is a wonderful method for thinking about how do we naturally acquire fears and how do we naturally overcome fears. So we naturally acquire fears through aversive events. You have a couple of accidents when you're driving, you're going to become fearful of driving. But if you keep driving without any more accidents, you'll become less fearful of driving. However, if there's a deficit in the extinction process, then fears will persist. And that's what we have been looking at for a long time now. Now, this is an old but a very, very telling set of findings. So here, we're looking at children, 8 to 13 years of age. We're comparing control children to children who are at risk for anxiety because their parents have anxiety or depression. They themselves don't, but their parents do. That puts them at risk. And we took them through that regular fear conditioning and extinction paradigm. We didn't use shock. We used a loud tone. It was not a good idea to shock kids. But what you see is that there's no real difference during the conditioning phase. So this is the stimulus that's paired with the loud tone. This is the stimulus not paired with the loud tone. Here's extinction. But look at this. 1 to 2 weeks later, the at-risk kids have not lost any of their fear, even though they've been through repeated trials here, which says that thing no longer predicts shock. It's as if they're not updating their memories. And if we go to children who actually do have anxiety disorders, you see that's augmented even more so. So they acquire a stronger fear than the control subjects. They don't extinguish at all, and they hold on to that out to 1 to 2 weeks later. So we think of extinction from a learning theory perspective as involving prediction error. And what we mean by prediction error is that there's a contrast between what you expect to happen, so you're expecting to be shocked, and you're not shocked. And that mismatch between the expectancy and the actual event is what should be driving extinction learning over time, as represented by this hypothetical learning curve during extinction. And so it's almost as if these kids who are at risk for anxiety or themselves have anxiety, something is impairing that ability to learn from prediction error. So they're experiencing prediction error, but they're still expecting threat on the next occasion. And so we have now two things going on. We have a generalized expectancy of threat that's represented by this sort of waking up, cortisol going at a high level, and tendency to interpret ambiguous situations in a threatening way. We have this spread of expectancy of threat to things that should be safe within a threatening context. And we have this holding on to fear and not updating memory when things that used to be threatening are no longer threatening. So if we went back to the example of the kids on the playground that I gave before, what that would look like is that the bully has been rehabilitated. They're completely over their bullying behavior. They're very friendly. But the child or the person who's at risk for anxiety or experiences anxiety still sees them as being a threat. So they're not updating their memory. And we've even done other research where we've tested the transfer of safety, and the parallel to that would be if a teacher were present with the bully and controlling everything that the bully did. So the teacher obviously represents safety. The at-risk kid or the anxious kid is still going to expect that the bully will hurt them. So they're not updating memory, they're not transferring safety information. So we have all of that, and then there's one more feature, and that's avoidance behavior. So it's very logical to avoid situations in which you expect threat to happen, because otherwise you might get hurt, right? And that's what we see clinically. So when patients come to see us for treatment, one of the biggest issues they're dealing with is that they're avoiding situations where they expect to be threatened. But the problem with that is that that literally prevents the opportunity to update information about safety, because they're not allowing themselves to even go through the experience of extinction. So we test that, for example, this is a common measure we use, a behavioral avoidance test, of how easily can you go from looking at the object, such as a spider in a terrarium, to actually holding the object. And that's one of our key measures of behavioral avoidance. We've also done experimental research looking at avoidance at the cost of losing reward. So what we find is that anxious individuals will avoid the situation in which they expect to be threatened, even if it means they're missing out on other rewarding opportunities. And that would just be represented here clinically by the socially anxious person avoiding going into a social situation, even though there might be job opportunities for them if they were to join. And so that avoidance behavior really becomes a major driver of the persistent nature of irrational fears over time. So now, if we look at this sort of consolidation of information about an expecting threat to happen and seeing threat everywhere, spreading the threat to what should be safety, failing to update memories and persisting in seeing threat despite evidence to the contrary and avoiding situations, how does that look at a neural level? What's going on in the brain? Now, I'm not a neuroscientist, but I use neuroscience to guide the way that I think about treatment and management of patients. We know that the threat circuitry, as it's called, largely involves areas such as the amygdala, which is very central to the detection of salient and threatening stimuli, the insular cortex, which is very relevant to interoceptive arousal and responses, the anterior cingulate cortex, which is very relevant to fear expression, the hippocampus, which is very relevant to memory formation, and the ventral medial prefrontal cortex, which has a major role in regulating and inhibiting fear and having inhibitory influences over the amygdala. So if you are actually running from a tornado, or if you are Walter Mitty actually escaping the volcanic eruption, for those of you who saw that movie, these would be the areas of the brain that are lighting up. But how does that look in anxious populations? So imagine now you're in a magnetic resonance imaging scanner. You're lying there, you look up at the screen in front of you, and there's a video. And the video is showing a room that's filling up with an audience. And you are told, you know what, that's the audience gathering for you when you have to go there to give a speech right after this scan is completed. So it's preparing for you. And what we're doing here, of course, is comparing individuals with social anxiety disorder to healthy controls. Here's the first audience member as they walk in, the second audience member, the third audience member, and as you can imagine, you're seeing a significantly greater change in amygdala activation in the socially anxious individual relative to the healthy control. Makes sense, right? Now, let's say you're still in the scanner, and what you're doing now is you're looking up and you're seeing video clips of yourself giving a speech that were recorded the day before, 30-second blocks, and then you're seeing 30-second images of another well-known public figure giving a speech, Katie Couric at the time. And these are sort of going back and forth. And what we find is that the socially anxious individual is having a stronger functional connectivity between the amygdala and the insular cortex, that sort of area very relevant to interoceptive arousal, as they view themselves compared to when they look at Katie Couric relative to healthy controls. And so that's simply indicative of a greater fear response, we think, to stimuli that should be threatening to these people because they're socially anxious. And in socially anxious individuals, to see yourself perform is threatening. But that makes sense. What's more telling is whether individuals with anxiety and depression, how their threat circuitry, their brain regions are responding to generic threat. And so that takes us back to the Pavlovian fear conditioning and extinction paradigm that I showed earlier. So what we've done now, and this is an ongoing study called the Brain Map study, is that we've taken 18 to 19-year-olds and done a whole array of measures, including the fear conditioning and extinction paradigm that I explained before, while they're in the MRI scanner so we can do neuroimaging. These individuals are not selected to be anxious or depressed. It's a normative sample. And what we've done is said, okay, at time 1 here, because we follow them over 4 years and repeat everything, we're just analysing these data. But at time 1, is there any relationship between how their brain is responding to fear conditioning and extinction and their sort of dimensional symptom severity, even though they don't have disorders yet? And what you see, and the strongest effect, is during extinction. So paralleling in some ways the behavioral work that I demonstrated earlier with the at-risk kids, during extinction, individuals who are showing higher levels of anhedonia. Anhedonia is a construct of lack of interest in activities, lack of positive emotions, and it's one of those constructs that puts people also at risk for anxiety and depression. That the higher the anhedonia, the weaker the extinction that's taking place, as represented by increased threat responding to that stimulus that's been extinguished. So that's happening in the amygdala and the anterior insular and the dorsal anterior cingulate cortex. So extinction is not working as well at the brain level in these individuals who are showing symptoms that could predict anxiety and depression in the long term. Now, of course, we have to follow this out with a lot more analyses of functional connectivity, and also, does it actually predict the development of anxiety and depression? But we will get there. So, if we have this notion that a generalized expectancy of threat is somehow interfering with that extinction, that prediction error learning, then the question is, how do we optimize extinction to help these individuals learn to overcome their fears and even prevent the onset of disorders? And so, of course, extinction is the basis of exposure therapy. Exposure therapy is a widely used clinical technique where we help people face the things that they're afraid of systematically and repeatedly, blocking any kind of avoidance behavior because that would impair extinction, in order for them to learn that the thing that they're most afraid of doesn't happen. So it's extinction. But I've just said that the people who need to go through exposure therapy have deficits in extinction. They have deficits in the very thing that we're trying to capitalize on as we go through exposure therapy. So how do we augment that? How do we help them to optimize their extinction? And it's not just about fear reduction. It's not just about be less afraid. It's not giving drugs to reduce fear. It's not helping people to relax, because that's just going to lead to a return of fear later on. What we have to do is get to the underlying mechanisms of the prediction error learning and try to augment there. And that shift, where we've moved from fear reduction to learning mechanisms, is actually where my research has had a most impact on the field, because clinicians nowadays have moved away from fear reduction per se and onto what's called an inhibitory learning model. So how do we do that? Well, I've spent years trying to study how to do that, and there are lots of different pathways in which we can try to enhance that formation of that updating of the memory, the extinction learning, and its consolidation and retrieval over time. I'm not going to go through all of these. I'm going to select a few examples, and I'm going to start with leveraging the prediction error component. So, clearly, if we want to do exposure therapy, and if we're basing it on extinction, it has to be based on the notion that you're violating expectancies. Because remember, it's the mismatch between what you expect to happen and what actually happens that drives learning. It's no good doing things that don't teach you anything new. So let's say this person, and I always use spider phobias because it's just easier, but this applies everywhere. Let's say the person says, I think that if I touch a spider, it will bite me. Well, if that's what they think, it makes no sense to do exposure to having them just look at a spider. They have to touch it. Because by touching it, then they can get the disconfirmation that it doesn't actually bite them, assuming it doesn't bite them. But we have to build that in, that's a requirement. And because their expectancy of threat, that tendency to expect threat everywhere, seems to somehow mitigate the value of each individual prediction error trial, at its simplest level what we do is we just try to get them to appraise the prediction error, to focus on the prediction error. So we constantly are saying, what do you expect to happen? And afterwards, did it actually happen? What did you learn? What surprised you? And that sounds simple, but it's so different from the way exposure therapy is normally done. Exposure therapy is normally about, did your fear go away? And we're not about fear reduction, about did the learning take place? And then if this this practice of prediction error rehearsal, I would call it, if we do that repeatedly over time, so let's say they go through an exposure therapy, and then at 4 hours, 24 hours, and 48 hours later, we ask them to retrieve that memory of the prediction error and to consolidate it and think about it again, we've actually found that that improves the long-term outcomes in comparison to control conditions where they go through the same exposure but they don't practice that retrieval. They retrieve other things that are irrelevant. And that's interesting for us because where they're both groups are doing exposure but one's doing the mental rehearsal on top. So it's a hard comparison to make. They're already getting some benefit from the exposure, but you see the group that does the mental rehearsal is showing much greater reduction in their self-reported fear and much greater likelihood to go and actually pick up a brand new spider that they hadn't seen before than the first group. So that's one way. It's a simple way of doing it. But we can actually change the conditions of learning in order to augment that prediction error. And here's what I mean by that. Compound extinction. Compound extinction is based on the assumption that if the threat doesn't occur, the unconditional stimulus, the threat does not occur in the presence of two predictors, the learning's going to be greater than if it doesn't occur in the presence of one predictor, because two predictors give you even greater mismatch. And remember, mismatch between your expectancy and the outcome is what drives learning. So if we translate that clinically, the way we do that is if somebody's fearful of spiders, we'll start off with presenting one spider. They're getting lots of learning here. Oh, that spider's not biting me. It's not biting me. Oh, it's not going to bite me. No more learning is happening here. So we bring a second spider in. And the second spider brings the expectancy back up. This one's still here, but now there's spider 2 thrown in. And then there should be more opportunity for learning. And experimentally, that's what we've demonstrated. That compound approach gives you better effects than a single approach. And here's another way. It's called occasional reinforced extinction. So usually with extinction, it's unreinforced, meaning every trial is without the US pairing. So if somebody's socially anxious, every trial is going to be positive, good social outcome. Remember here, they're not really learning anymore because there's no mismatch going on. Their expectancy is already dropped. But if you built in an occasional aversive event, your expectancy is going to go back up again for the next trials, and that's where learning can take place. So you have, as long as the next trials are positive outcomes. And we did the first human study showing that that works too. When you compare occasional reinforced extinction to regular extinction, they're much more anxious as they go through exposure because they're getting bad things happening to them every now and then. But in the long term, they're doing much better. But we need to do even more. Attention is critical. You can't learn if you're not attending. You have to attend for prediction error to happen. And there's lots of ways you can try to measure attention. And one thing that we have done to directly manipulate attention is called affect labeling. And what that means is, as the person is approaching the object that they're afraid of, let's say spiders, I know I keep picking on spiders, but it's easy, they're asked to think about, what do I see and what do I feel? Now, if you're asked to do that, you have to look at the thing you're afraid of, so you're directing attention to the object. And we compare that to reappraisal, where they have to come up with alternative ways of thinking, and we compare it to distraction. And that affect labeling, yeah, that's effective. It results in the future, when we bring them back a week later, they've gone through multiple sessions of exposure, we bring them back later and test their reactivity to a brand new spider in a brand new context. And those who went through affect labeling have less skin conductance response to the new spider compared to at the end of treatment than every other group. And they're more willing to get closer to a brand new spider, at least than the distraction group. And we've replicated that in spider fears. We've replicated that in public speaking fears. We've also been piloting this with PTSD, which is a brand new approach to the treatment of post-traumatic stress, where we have veterans with PTSD look at images that remind them of their trauma, and then they just label their current emotional response to the image. So again, it's forcing them to attend. And very brief training of this sort in our pilot work was amazingly effective in reducing PTSD symptoms and reducing neural response at the level of amygdala change to images of combat when they were in the scanner. So it's very promising. Okay, I'm going to shift to the most recent set of work we've done before I go on to the appetitive system, and that's context attenuation. Context attenuation is critical because extinction is context specific. So the prediction error learning is gated by the context in which it occurs. And that's really unfortunate for us clinically, because it means after the person goes through exposure therapy, their fear is likely to return when they go to a completely different context. Return of fear. Now, Mike Fanzelo in our department has been the world's leader in identifying that the hippocampus is really critical to the encoding of extinction memory. And his work, he's shown that he can lesion the hippocampus, which we're not going to do, but he can lesion the hippocampus, or he can temporarily interfere with hippocampal functioning with a drug called scopolamine, which is a cholinergic antagonist, and in rodent samples, that releases the contextual specificity. So the extinction effects generalize, which is great for us. So we set out to do the first study of that in humans. We used individuals who were very fearful of public speaking. They had social anxiety disorder. We randomized them to placebo, scopolamine of 2 different doses, double-blind administration, every time they went through exposure. And to do this, we used virtual reality as our method of exposure. Now, this is not exactly the virtual reality. It's hard to show it on a screen, but you can get the idea of what it looks like as people were asked to get up and speak. So they could look around. They could go down. They could look around. And then they had to give 7 speeches, a little bit like me speaking to you right now. And they did that 7 separate times, 7 speeches each time. So they gave 49 speeches. And then our goal was to test, does the scopolamine result in less fear when they're tested in a brand new context, so different than this one. And so for the brand new context, again, this is just to demonstrate, it wasn't exactly like this, but you can see it's a very, very different kind of audience that they had to speak with. Now, these were all counterbalanced, so there was nothing that said that one was necessarily more threatening or dangerous than the other. But what we expected is that if the scopolamine is actually working it should result in less fear when they did this compared to placebo. And then because time alone is a context, we then tested them 1 month later in the same context that they did exposure therapy in, again with the expectation that if scopolamine works, they should experience less fear there. We did look at a task that's hippocampally dependent and found that scopolamine was affecting that task in the way it should, so that gave us a little bit of confidence that scopolamine was affecting hippocampal functioning, because we really didn't know. And we got some interesting results. So in this immediate test, you can see that the 2 scopolamine groups are showing less fear arousal than the placebo group. This is using skin conductance, whereas they did not differ when they were retested in the same context in which they did exposure therapy in. So there was less fear in the new context for the scopolamine groups, or trends for that effect. And at 1 month follow-up, the 2 scopolamine groups showed less fear than the placebo group at 1 month later. And both of these were drug-free. So this is not just due to the drug. But the third finding that we had was that, surprisingly, the scopolamine groups also reduced fear during the actual sessions of exposure, which is a little hard for us to explain and we're now looking into. Scopolamine was benign, there were no adverse effects. We had medical staff around all the time to make sure, and so this suggests that a drug like scopolamine could actually help with the generalization of exposure therapy as we move forward. Very briefly, extinction, we want to generalize. We want the effects of extinction to spread. And so we're trying to interfere with hippocampal functioning. Fear acquisition, we actually want the effects to be constrained, right? We don't want them to spread. So after traumatization, fear usually spreads. And as I said before, anxious individuals, it spreads even more. So is there a way that we can limit that spread of fear right at the point of traumatization? And our dear colleague Tom Miner, who passed away a few years ago, had said, you know what? Glucose may be an answer, because the hippocampus is very sensitive to glucose, and normally the hippocampus becomes deprived of glucose right after trauma. So we did the first human study and found that yes, double-blind administration of glucose did increase the fear of the context in which shock occurred and separated it, discriminated it very nicely from the context in which shock did not occur. So fear did not generalize to the other context, whereas placebo was just a mess. And so, and we've replicated that in a more recent study, which I won't go into the details. So what this is saying is glucose, benign glucose, might actually be a way of helping to contain the spread of fear, something that could be particularly useful for first responders. Okay, I'm going to move now to the appetitive system, which has been the focus of our most recent work. And here I'm going to be talking about the dampened anticipation and savoring of reward. That what seems to be a risk factor for depression anxiety is low levels of interest in, motivation for, or savoring of positive events. So it's all around positive emotions. Back to our 627-person longitudinal study, low trait positive emotionality as a construct, which is different from negative emotionality. These are two separate constructs. They're orthogonal to each other. That is a predictor of who develops depression and anxiety disorders, and we've also shown that positive affect buffers the impact of stress. So individuals who are highly stressed but also have high positive affect are less likely to develop an anxiety disorder or depression than if they have low positive affect. So it's a good protective factor. And most recently, one of the students in our lab has looked at interpersonal support. And interpersonal support, feeling connected and supported by others, is a great way to access positive emotions and probably to activate that sense of reward. Now, with that, I'm going to ask you to do a special task. I want you all right now to just think of, don't get your cell phones out yet, just think of a person who's very dear and near to you. And just identify that person. You may have seen them recently, you may not have seen them recently. I want you just to identify that, make a mental note so it's ready later, okay? We'll keep going and come back to that. The neural pathways that go with this low level of anticipation and response to reward have been established more by other labs than my own. Where we differ is we're doing very large samples now to identify these patterns. So it's usually the ventral striatum and the orbital frontal cortex that has been identified as the reward circuitry. This is a study with patients who are depressed or anxious. We have 200 of them, and we take them through a task where they're basically in the scanner shown signals which say you're about to get rewarded money or you're about to lose money. And you see a very nice curvilinear relationship so that as they expect to win money, you get greater signal activation in the nucleus accumbens. Similarly, if they think they're going to lose money, and in the caudate head. And we find that these patterns in this patient group are moderated or influenced by how anhedonic they are. If they're more anhedonic, if they have less of that interest and motivation for reward, these are muted. You see less of that signal activation. So deficits or hypoactivation in the reward centers of the brain. We also looked at how do they react when reward is actually given. So at the moment they've said, you've now gotten $5, or you've now gotten $1. And we see a nice correlation here in this patient sample with orbital frontal cortex activation and again, anhedonia. So the more anhedonic the person, the more they say, it's hard for me to get motivated, it's hard for me to feel pleasure, the lower the level of OFC, orbital frontal cortex activation, when they are given a sign that you've been rewarded. And so nicely, we've replicated that finding in our other study, if you remember, the brain map study. These are 18 to 19-year-olds. They're not disordered, but even in that group, we see the same exact pattern where the level of anhedonia, which is now at a lower subclinical level but still ranges, correlates with the level of orbital frontal cortex activation, like a hypoactivation. They're not getting as rewarded at a neural level by, here's some money for you. So that's led us to this question of, how do you teach people to anticipate reward? How do you teach people to savor reward? And it's a really important question because up until now, all of our treatments, our behavioral treatments, our pharmacological treatments for depression and anxiety have not been successful in helping people to feel more positive. They help people to feel less negative, but they don't make people feel more positive. Maybe ketamine helps, but these treatments don't. And so we developed a positive affect treatment. So this is, in psychological worlds, a brand new treatment. And it starts off with behavioral training, where we have people engage in rewarding activities like social interaction, because that's one of the ways to enhance positive emotion, or listening to music, or going for a walk, or completing something that's been a good feeling of accomplishment. That's in and of itself not that new, but this behavioral or mental rehearsal is what is critical. So after they've done those activities, we spend the majority of the therapeutic session having them reflect on, what did you feel? And at that moment when something positive happened, what lifted you up? What did you experience? What did you see in front of your eyes? What was your sensation in your body? So we're trying to consolidate that memory for the positive experience. And then we combine that with cognitive training, where we train them to search for the positive in complex stimulus arrays, to imagine positive outcomes, to attribute positive outcomes to themselves. And after they've gone through this, then we think they're ready, because these are very depressed and anxious patients, then they're ready for compassion training. And so the last portion of our treatment is all about intentions and actions of loving kindness, gratitude, generosity, and joy associated with this mental rehearsal of what did that feel like. So now's your time. Pull out your cell phones. And take that person that you identified earlier as the person who's near and dear to you, and just send them a little text. Just send them a little note. Some act of caring, kindness, interest, wanting to help. And if you don't have the capacity, just make a mental note of what you would say. And I will do the same, if I can find my phone. So putting your phones away. Away. Putting them away. Just think for a moment. Just sort of think. What does that feel like? You don't have to say anything. Just think. What does that feel like? And you probably feel a little good. And maybe your ventral striatum, maybe your nucleus accumbens lighting up just a little bit. Especially when you get a response from the people that you sent your text to. And for patients who are depressed or anxious, this has an amazing uplifting effect, because it's empowering and it feels like they're contributing not only to their own worth, but to the worth of others. So acts of loving kindness, gratitude, generosity, and appreciative joy. Now, that was just a little taste for you to see, and I'm going to get to something else in a moment. We took this positive affect treatment and we did a randomized controlled trial, and we compared it to standard psychological treatment for depression and anxiety, which is all about reducing negative emotions. And yes, we can separate those two things. We can train therapists to only talk about positive emotions and other therapists to only talk about negative emotions. We record every session. We have independent raters rate. And yes, the therapist did a good job. They separated these two constructs. And then we compared the effects. And what we found is, so PAT is the positive affect treatment, successfully increased positive emotions up to what was a normative level in the population. That's never been done before, because the treatments have never been effective at raising positive emotions, and it was more effective than the other treatment. We called it NAT, negative affect treatment. It was also more effective at reducing negative emotions, surprisingly. So PAT was better at doing that. It was also more effective at reducing depression. It was also more effective at reducing stress and anxiety. It was also more effective at reducing suicidal ideation. So we're now, and just so you know, it's really hard to get differences between two active treatments in clinically severe samples. So to see this is very promising. We're now funded to do a replication where we're looking at lots of measures of threat and reward sensitivity over time to see what's happening. But we're also going in one more direction, and that is virtual reality again. Because for patients who are chronically depressed and have isolated themselves so much, it's very hard to even find rewarding activities or to get motivated to engage in rewarding activities. And virtual reality gives us a chance to present those experiences in a controlled way. So I'm going to show you 2 attempts at a version of virtual reality. And I want you to pay really, really close attention. They're very different from each other, and they're not true virtual reality because I can't do it on this screen. But imagine you had goggles on and you were in here, and just pay attention to each one. and they're very brief. Okay, so hold that in your minds. Now we're going to do a different one that's very different, and hopefully I can do this. Okay. So we're walking through a painting. We can drag. Trying to give the illusion you're looking around. I don't want that. Now it gets psychedelic. So just thinking about those for a second, if you could just think back to what part of those scenes captured your mind? What was interesting to you? And if you can just in your mind reflect back, what did I see? And when I saw that, what was I physically feeling in my body? What was I thinking? What kind of label would I give my emotional experience? And that is the way in which we try to encourage savouring of positive experiences through virtual reality, and then having the person transfer that over to autobiographical memories so it becomes more personally relevant over time. So that is a glimpse of the kind of research that we're doing. Obviously, I'm trying to bring together the sort of appetitive and defensive systems in the long term so that we're not just looking at these as independent constructs. And for my own final positive affect induction, I'm going to finish. So these are Tasmanian devils. Yes, they are babies, and they don't grow up so nicely, but this was from my window when I last visited Tasmania, well, the island off the south of Tasmania a few months ago. Tasmania is full of temperate rainforests, which you wouldn't expect, and wonderful hiking. And this is my favourite beach in the world. It's called Wineglass Bay on Freycinet Peninsula, because you can only get to it by hiking or boating. It is precious. Thank you very much.
I'd like to thank Professor Kresk. If we have time for one or two questions, if people would raise their hands, I think there should be a mic that will go around.
Can you speak a bit more about what you were showing at the end how you have somebody go through a Van Gogh painting in virtual reality. How does that help with depression and anxiety?
Yeah, so the idea of the virtual reality is that we provide controlled positive experiences followed by this practice of mental rehearsal. So it's a good half hour afterwards and then at repeated intervals later to retrieve the memory of what they saw, to build in sensory and physical details to the memory, and recognize and label the emotion of positivity with it so that you can consolidate that memory and then practice retrieving it over and over and over again. And we follow that by autobiographical memories that were positive from the past, which typically tend to be very overgeneral and depleted for people who are depressed or anxious. And so we have them try to capture the details of the moments that felt positive. And when we've done that, I didn't present these results, just that alone, just the virtual reality alone has a significant impact on depression and anxiety, even without all the other stuff associated with it. I don't know if it would be enough, but it has an impact, and particularly for patients who just can't get out into the world because they're feeling so anhedonic. Yeah.
Among the various interesting aspects of your work, one thing that you didn't mention is humor. And I wonder whether humor has a role in the kind of work you're doing. So
humor certainly is a positive emotion and could very well play a role. We have not ourselves studied it, but I think from a clinical standpoint, it's just a little harder to use humor, at least to start off with, because of the severity of the conditions that people are dealing with. But I could see it certainly building up to humor. And when we do the virtual reality, people are often at the end smiling and laughing. I mean, the scenes vary. I showed you two extremes. I don't know, actually the elephants could be scary, I suppose, for some people. I thought it was kind of curious, but as I looked at it, maybe not a good choice. That we have, my favorite virtual reality scene is to be sitting with the band U2 around me, singing to me. That's a really positive scene. And there's humor in that.
We'll have one last one.
The positive reality therapy. Has this been integrated in any way to counseling for UCLA students who might be stressed out for midterms and finals, et cetera?
Not yet. So I haven't touched on all of the work we're doing for the students at UCLA, but we're doing aspects of the positive affect treatment, which is really about compassion and kindness and gratitude and generosity. That's one of our components within the STAND program of treatment. Virtual reality we haven't gotten to because it's an issue of scalability. Yeah.
Thank you.
So on that note, if I could... I also would like to thank everyone who has made this possible, the staff and the committee, the selection committee, the people who have put on the event itself. There will be a reception outside. So if we could just thank Professor Krask one more time, I'll send you.